Nurse Kat with NCLEX Mastery. Today we're going to do a tough question. So the last couple were a little bit of softballs. If you missed it, make sure you go back and review those. If you're new here, welcome. Make sure you comment download in the chat so we can get you access to the #1 test prep app in the App Store for NCLEX. All right, so only 44% of our learners get this question right. So I want you to lock in and focus with us for a minute. Now, lots of our questions have exam tips that you can see after you answer the question. I'm going to give you this one on the front end because I want you to be ready to apply these principles, okay? Actual problems before potential problems, A before P, acute before chronic, A before C, airway and breathing before circulation, A before C. Now, when we get into the answers, you're going to be like, none of these are airway, but one of them has the risk of acutely affecting somebody's oxygenation, and that's what you need to think about. All right, so we've got 4 patients to choose from who needs to be assessed first, okay? So we have somebody who has had a bruit, and they're scheduled for surgery for a AAA. Then we have somebody who had a heart attack 24 hours ago and has an elevated troponin. Then we have a client with a prosthetic valve and an INR of 2.4. And lastly, a client with hypertrophic cardiomyopathy and atrial fibrillation. Okay, so all of these seem acute. One of them is more acute than the others. All of them represent actual problems, but 3 of them have slid more toward being a chronic issue. And only one of them represents a very real threat to the person's ability to oxygenate. Drop your comments in the chat. Now, nearly 30% of our learners pick the person with the AAA. And don't get me wrong, AAAs are deadly, right? What's going to be the intervention for the AAA? What are you going to do about it? The surgery, right? If they're scheduled for surgery in 2 hours, like, OR's fixing to roll up and load them up on a gurney, okay? So you might want to assess them before they go. But as far as setting a priority for who's going to die first, it's probably not them because the surgery is scheduled. If it had been emergent, they would already be in surgery, right? So AAAs can be stable. And the bruit is totally expected for somebody with a AAA. So even though that seems really urgent, it's actually not so much, okay? So who does that leave us with? The person who had an MI and has an elevated troponin, well, we know they have an MI. We've got them on monitoring. We're doing their labs. They're getting appropriate treatments. They've been there for 24 hours. What else do you need to do with them right now? Okay. Then we've got our person with the heart valve. Now, out of all of these folks, that person is certainly the most chronic, certainly the most stable, and their INR is pretty much perfect depending on what kind of valve they have and depending on what their goals are from the doctor. But at the most, they need an adjustment in their anticoagulation therapy. There's probably not any danger there. That leaves us with the person with hypertrophic cardiomyopathy and atrial fibrillation. Now, here's where I think a lot of people don't choose it. Cardiomyopathy, you're just thinking, okay, it's an enlarged heart. We get people with enlarged hearts all the time. It's a person with AFib. We get people with AFib all the time. No big deal, right? Well, wrong, for a couple of reasons. One, this is new, okay? So Same reason you can't delegate a newly diagnosed person to a practical nurse, or same reason that you would want to get early vitals on somebody who's new, because they have the most potential to be not stable, right? Okay, so there's that part. But then also, the way that hypertrophic cardiomyopathy works, along with atrial fibrillation, is really significant to their care, okay? So let's talk about that. So for hypertrophic cardiomyopathy, blood already has a really hard time getting out of the heart and into the body because of where and how the cardiac muscle is thicker, okay? Now, that's already the problem that we're trying to address, is making sure that blood can get out of the heart and into the body. Well, what does atrial fibrillation do? First of all, it can be a complication of HCM, but also, are the ventricles going to have the blood supply the way they need it in order to fill properly, in order to get to the rest of the body? Let's throw in an analogy and see if that helps. So, hypertrophic cardiomyopathy would be like having a garden hose that is just a little kinked, right? Water can still get through, but you can tell that the water pressure is not great. But now also, you don't have great water pressure coming from the valve either, which makes even less water available to go through. So let us know in the chat. Did you get the question right? Were you almost there and just need to do a little bit more work? Or do you feel like those atria just kind of quivering and not really getting the holes filled where they need to be? That's okay, we've got